Today's topic is based on two parts. One is Japanese encephalitis and the other is filariasis. And why have both been clubbed together? Both have been due to Culex mosquito, due to the Culex mosquito. Okay. Now Japanese encephalitis is relatively new, but filaria is very old disease and very nagging disease in the sense that it takes a lot of time to get the disease, takes a lot of time to get cured. On the other hand, Japanese encephalitis is relatively new disease and it was unheard of say maybe 15-20 years ago, and now it's come in a big form in parts of India, and it's also created deaths, as a result of which the government has thought that this should also come into the vector-borne control disease program. Okay. So basically this is the name Japanese encephalitis because it occurred in Southeast Asia, Pacific and other places, and it affects both man and animals, and it's transmitted, caused by flavivirus, transmitted by the Culex mosquito. And every year about 30 to 40,000, 50,000 cases of JE are reported. Mind you, reported. Many cases are not reported. They say it's a headache or viral fever, something like that. So more than 3 billion people are at risk of developing the disease. So this, they say that the recognition goes straight up to 19th century. The first case was in 1871 in Japan. Okay. Then 1924, 27, 34, 35, all we had cases in Japan, epidemics rather. But they found that Culex was a vector only in 1938. That is, the first case occurred in 1871, but after nearly 50 years only they found that Culex was the cause. They thought it was a viral disease affecting the brains, so they couldn't find the cause till around 50 years later. And then it spread to Korea, China, Pakistan, India, Northern Australia and several other countries. Okay. So if you look at the global scenario, this is how it looks like. As usual, India is right in the center of the epidemic, and the northern parts of, you can see those parts are not affected. Which are the parts which are not affected? Which are the parts that are not affected? Okay, which are the parts that are not affected? No, let us say the countries. Which countries are affected by JE? As per this thing? Huh? Now, which countries are affected? Tell me. Just tell me, we're looking at this, which countries roughly? One is India. What other countries? Names of Southeast Asian countries? Names of Southeast Asian countries? Sri Lanka, okay. India, Bangladesh, Sri Lanka, what else? Myanmar, okay. So it's basically that side. But on the north, it is not there. Russia and the northern part is not there. Okay. So approximately half of the population lives in JE endemic areas. So the question is, will all of them get JE? Theoretically, yes. But it's only, most of the cases are from China, India and Southeast Asia. And as I said, there is under-reporting. People have a headache, fever, meningoencephalitis, they don't get reported. So there's a lot of under-reporting. So they say 58,000 cases reported in 2011. The actual figures will be much more, maybe over 1 lakh. And 15,000 deaths also occurred. Now remember, 58,000 cases reported, 15,000 deaths. So what does it mean? 58,000 cases reported, 15,000 deaths. What does it mean? What does it mean? Huh? What does it mean? 58,000 cases, 15,000 deaths. Huh? Huh? Yeah, mortality is 15 divided by 58. That's almost 25%. Okay, that's the importance. The cases may be less, but the mortality is very high. The death rate is very high. Fatality is very high. Okay, so in 1955, the first cases was reported from North Arcot district of Tamil Nadu and reported to CMC Vellore. Then the interesting part was many epidemics were there in the same year. Then West Bengal, UP, Bihar, UP, Assam, West Bengal and other places, Manipur, Pondicherry, Karnataka, Goa. And maximum cases were from Assam, 761 cases in the year 2014. And again, as the cases go, the deaths increase. Out of 1,657 cases, 761 cases, 160 deaths. Again, 160 by 76 is how much? Again 25%. So roughly a mortality rate of 25%. And Tamil Nadu 36 cases and 3 deaths. Okay. So again this same scenario, some districts are affected more, some districts are not affected that much. Green are the districts which are affected. So it belongs to the flavivirus group and genus flavivirus, and here it's similar to the West Nile and St. Louis virus. Now West Nile has just come into India recently, St. Louis has not come, but it's similar to that, and this helps the virus enter the cell, and the Indian strain is derived from the Muar strain which occurred in Malaysia, okay, and belongs to genotype 5. Now Japanese encephalitis is a zoonosis. What is a zoonosis? What is a zoonosis? What is a zoonosis? Any idea? What is a zoonosis? What is a zoonosis? Huh? When a disease is transferred? Okay, it's basically a disease that affects animals more and man get it incidentally, okay. So that's what a zoonosis. So it affects basically animals and birds. They include water birds of Ardidea family, okay. Mainly pond herons and egrets, cattle egrets. Now have you seen a pond heron and cattle egret? Do you have an idea what a pond heron or cattle egret looks like? Huh? Do you have an idea what a pond heron looks like? Karo, dekhicho? Pond heron? Have you seen a pond heron? Or a cattle egret dekhicho? Acha. Ito dekhicho? Huh? Walk. This is called a pond heron as per the okay. Okay, this is also, as you say, bok, cattle egret. So these are terms, okay. So here these are affected most, okay. Natural hosts include water birds, mainly pond herons and cattle egrets. Pigs play an important role in the cycle. Remember this? Pigs play an important role in the cycle. But pigs are amplifier hosts, okay. They allow multiplication without suffering the disease. So you won't find a pig suffering the disease. They allow multiplication of the virus. And man is a dead end host. That means after him he doesn't transmit to anybody else. So it cannot be transmitted from man to mosquitoes also. So after man gets it, it's over. Another mosquito will not bite him and transfer to somebody else. So these are some important things. It's a zoonosis. Its natural hosts include water birds like pond herons and cattle egrets. Pigs play an important role, and pigs allow multiplication without suffering the disease. That's why it's called an amplifier host. It just amplifies. Like sound is amplified from that way. Then man is a dead end host. It doesn't transmit after you get it, the mosquito will not bite you and transfer it to your friend. So this we saw this. Okay. So this is how it is transmitted. Mosquito bite, then it goes JE transmission, and there are a lot of other things. And the pig acts as the intermediate, as an amplifier host only. So vector, what is a vector? Vector is a Culex mosquito species, Trichinotrichus. It's rice breeding mosquito, okay. So it occurs mainly in the paddy fields. And there are other vectors also. But mosquitoes are responsible for the pig-man cycle, okay. Pig mosquito, pig cycle, as well as bird mosquito, bird cycle. Very rarely you find Aedes and Aedes and Anopheles also as vectors, but they are not usually taken. For us, practical purposes, we look at only Culex. So Culex is a vector for Japanese encephalitis. So Culex occurs basically breeds in paddy fields, stagnant water and ditches, and they rest outdoors. Like in contrast to Anopheles, Anopheles, where does it rest? Where does Anopheles mosquito rest? Anopheles mosquito কোথায় থাকে? ঘরের বাইরে ভিতরে মাঝখানে কোথায়? ঘরের বাইরে, okay. না ভিতরে. So here it's very clear. Culex is they rest outdoors and are predominantly zoophilic. And less than 2% feed on human beings. Therefore, you need a high density of mosquitoes. Prochur mosquito চাই Culex, নালে এটা আসবে না. Okay. Then most of the places where paddy cultivation is being done, that is where this occurs. It won't occur in, say, some place like Kolkata or some other place, but it will go to some place where there is a lot of paddy cultivation. Maybe Burdwan is one such place. And patients once infected remains infected for lifetime. Okay. So this is a Culex mosquito. You can see it's not very distinctive as compared to Aedes or Anopheles, but a mosquito is the agent for this. Okay. So mode of transmission, man gets infected by the bite, human to human transmission does not occur, and it does not spread from humans to the mosquitoes either, and there is no lab contamination or lab spread. So it is just mosquito biting man, that's it. No reverse, that is after the man is infected, another mosquito will not bite him and transfer to somebody else. Again, if somebody is infected and shakes hands with somebody else, he will not transmit the disease. So this is a very simple mode of transmission. Clinical features is incubation period is between 5 to 15 days. Most of the infection occurs in childhood and adults have less. Okay. And it's usually asymptomatic or mildly symptomatic. So it's just like a headache, fever, etc. And less than only 1 in 250 infections show symptoms of encephalitis. And 30% of people who show symptoms, however, die of the disease. So if somebody's got a headache after fever, the headache is not getting improved after, there's high fever, then think of encephalitis, do the necessary tests, do this test also. Because 30% of people who show symptoms die from the disease, and 40 to 50% who survive suffer from residual defects like paralysis, then recurrent seizures or inability to speak. So this is the thing. Not everybody gets infected by JE, but people who get affected, they can get affected in a severe way. They can die, and people who don't die, they have residual problems like seizures, paralysis, etc. Okay. So in symptomatic patients, the disease manifests in 3. First is acute prodromal phase, before the central nervous system entry into the brain, just like any other fever, headache, like GI disturbance, headache, malaise, etc. After it enters the brain, then the encephalitic syndromes takes over. You have rapid onset of high fever, neck stiffness, seizures, spastic paralysis, and rash. And death. Then you have recovery phase, complete or partial recovery with neurological deficits, cranial nerve palsies. So the first phase, acute phase, just like a fever or jor hoiche, that's all. But the second phase, it becomes more. You have rapid onset of high fever, neck stiffness, seizures, spastic paralysis. What is spastic paralysis? What is spastic paralysis? What is spastic paralysis? RK paralysis. What is spastic paralysis? Huh? What is spastic? What is the opposite of spastic? Flaccid, okay. So she said spastic is one, flaccid is one. Now what is spastic? What is flaccid? What is spastic? Huh? Spastic is just think of your fingers. You put your fingers like this and it drops down on its own. That is flaccid. On the other hand, if you put it like this and stays tight, that is called spastic. So here you are having spastic paralysis, okay, and death. So because the diagnosis is very dicey, you have to rule out all other clinical things like acute meningitis for various reasons. So rule out all other tests, then you do the laboratory test, specific test, antibody detection. You have the RT-PCR and ELISA, and tissue culture and mouse bone inoculation. IGM ELISA is the test of choice, and provided samples are collected 3 to 5 days after the infection. So it's important that the sample is collected after 5 days. You will not get the disease. It will come as unidentified meningoencephalitis or something like that. So for that, you need IGM ELISA, which is collected 3 to 5 days after the infection. So here again, there are some definitions. Probable case, clinical suspect, clinical case. Clinical suspect is febrile illness of variable severity associated with neurological complaints, from headache to meningitis and encephalitis. Headache, fever, meningitis, signs, stupor, disorientation, coma, tremors, paralysis, loss of coordination. Here is a clinical suspect. He could be having JE, he could be having something else, he could be having some other meningoencephalitis. So he is a clinical suspect. Nothing has been done, no test has been done. He's just come straight to you. Second one is probable case. The test is We have got the IGM antibody test, and we have got the ELISA test also positive. Okay, this suspected case, but he's got all the tests are also positive. Then case definition. Case definition, confirmed case. The previous one was suspected case and clinical suspect and probable case. This is a confirmed case. JE IGM antibody 4-fold rise. Okay, in paired sera, or detection of virus, antigen or genome in blood or tissue, or PCR. So this is the confirmed case. This is the definition for JE. So you have a suspect, you have a clinical suspect, you have probable case, and this is a confirmed case. So treatment, there is no treatment. Clinical management is supportive, and fluid and electrolyte should be corrected, loss. And seizure management is necessary. Airway management is crucial. So because it affects it's encephalitis, you can have seizures. Seizure means fits, and there can be the airway can be compromised. So that's essential. Control measures, control of the reservoir, control of the vectors. Control of reservoir, birds and various animals act as reservoirs. Now, almost impossible to take care of reservoirs. How many birds can you take care of? Okay, how many animals can you take care of? So pigs act amplifying hosts, but yes, because pigs are few in number, you can discourage people to grow pigs, so that once they are removed, then the chances of the Culex mosquito coming there are less. Okay, so pigs act as amplifying hosts. That is so control of reservoir is the first part. Control of the vector. Here we have insecticide spraying is out of option because vector is in paddy fields. So what happens if you spray insecticide in paddy? What will happen? What will happen if you spray insecticides in paddy? What will happen if you, can you eat that food again? Yes or no? Yes or no? Huh? You're spraying on the paddy field. So will you eat this paddy? No. So that is one of the reasons why we cannot use spray in the paddy field. So again, the only thing we can do is echo management, alternate wetting and drying, then ultra low volume insecticide. Okay. Spraying by fogging has been found helpful. A sterile male technique. These are some of the things which have been done. You cannot do large scale insecticide spraying because of the possible toxicity. Then you have vaccines. This is important. 4 vaccines have been introduced. One is mouse brain, cell culture based, live attenuated and live chimeric vaccine. So mouse derived kill vaccine is called a Nakayama Beijing strain, and 1 dose followed by 2 booster doses. Okay, this is widely used. It was widely used in the past, but it has severe side effects. And since 2007, it is banned. It's no longer used. But it was expensive also. It was but ideal for travelers, like people traveling to various countries where there was Japanese encephalitis. But because of side effects, it stopped. Then live attenuated vaccine. This is effective during mass campaigns. Okay, when you have a number of people getting vaccinated, it is effective. Presently used in India, 2 doses given subcutaneously, safe up to 15 years, not recommended for adults. It's also called 14-14-2 vaccine. Then this is Jenvac vaccine. This is now introduced, varicocele derived purified inactivated vaccine. 2 doses intramuscularly, 28 days apart for routine immunization, and single dose during epidemics. 98% conversion occurs, seroconversion occurs after 2 days. And launched officially in 2013. It's available now, it's freely available. It's available in the Indian market also. Okay, now this is, this JE comes under the National Vector-Borne Controls Program. And here we have, it was started in 1955, it started from Vellore, but first epidemic was surprisingly in Burdwan in the year 1973. Okay, so first major epidemic was not very far. Was it surprising that it occurred in Burdwan? Was it surprising that it occurred in Burdwan? Bola? Was it surprising or natural that it occurred in Burdwan? Huh? Was it surprising or natural that it occurred in Burdwan? What is your opinion? Surprising. Who's saying surprising? Why is it surprising that it occurred in Burdwan? Who said surprising? No, just who said it? Bolo. Maybe you may be right. Bolo. Is it surprising that it occurred in Burdwan, or is it natural that it occurred in Burdwan? Sheda bolo. क्या ये होना चाहिए था या नहीं होना चाहिए था बर्दवान में? अब say something. बोलो बोलो. You may be wrong. No problems. बोलो. মশার জন্য, মশা তো আমরা পড়ছি রে বাবা, মশার জন্য না। I'm talking about bird-borne. Is it natural for it to occur in bird-borne epidemic, or is it a bit unusual that occurred in bird-borne? Huh? बोलो बोलो. Why natural? Yes, exactly. It's natural because bird-borne is the rice granary of Bengal, you can say. ওখানে maximum paddy fields আছে. That is why it's natural to have it in Bengal, in bird-borne. That's why I said quite natural. Had it been in Darjeeling, I would say no. It's very unusual. Here we have paddy fields in plenty. Rice is got from bird-borne. That's why. So we have 2005 we had epidemic in UP, and 2006 this vaccine was inaugurated, was introduction in the year 2006. So they've also developed these guidelines, and the work of the program is there, and they've got guidelines for surveillance and case management. And the aim of this is to increase JE vaccination. So first JE vaccination was only in the few districts where JE was there, but now they've expanded it. And not only that, they strengthen surveillance, estimate disability burden, improve nutrition status of children at risk for JE, and carry out IEC and BCC activities regarding JE and acute encephalitic syndrome. Can you name another state where you have acute encephalitic syndrome? Cases occur periodically. That particular district or city in another state. बोलते पारो? Huh? Yes? Yes, बोलो. Chandigarh, not Chandigarh. She's gone to Chandigarh. No, come closer. Huh? Huh? I heard the answer from somebody. बोलो. Tell me. Bihar. Very good. Bihar where? Bihar which place? Anybody idea? Muzaffarpur. So Muzaffarpur, they have acute encephalitis syndrome, and they said it is due to eating lychee. Okay, lychee fruit. So a lot of people they used to take lychee and they used to get this acute encephalitic syndrome, AES. So this has been included in the endemic districts, and there are various sentinel sites, research areas for JE, and trainings for pediatricians and district medical officers and others regarding JE management, and also entomology centers have been established over the country for trainings on mosquitoes, etc. So vaccination mass JE campaigns where children in the age of 1 to 15 years, 2 doses are given 0.5 ml subcutaneously, and first dose is given along with measles, second dose along with booster dose of measles. So JE and measles are combined together in the routine immunization program where there is endemic districts. Okay. So this is the vaccine which is used. So I think as far as JE is concerned, this is all. We'll just get back to the next part of the thing. Let me see how we do. So we go to the second part, which is filariasis. Okay. Now this is again another borne by mosquitoes. Here, unlike JE, which is very swift, acts with headache and all, this is takes a long time. They are caused by infection with roundworms of the Filarial type, and this belongs to a group called Elephantiasis. But now here, what are the commonest worms that occur? We have Uchraria bancrofti, we have Brugi malai, and these are two main things. So 120 million people in 80 countries and 1 billion at risk. Okay. So again, if you look at the worldwide map, we have cases in India, Southeast Asia, and what is the other country which is there? Which other countries is this? The red one? Which countries are that? Red is which country? Huh? India is there, India, other than India? Huh? Indonesia, Papua New Guinea, I don't know. Badike ki hai? Badike lombata? Africa Rajya, okay. So basically Africa, India, somewhere we have some other, Malaysia, Indonesia, etc. All these things are there, okay. Since you mentioned about, you mentioned Papua New Guinea, right? Okay, just remind me to come back for 1 minute after the class. I've got a small point. So what happens here is, these are all slender worms which block the lymphatics. Okay. And this blockage leads to edema. So the body swells up because the worms block the lymphatic passage. And they live for 5 to 7 years, produce millions of offspring. So this is how it looks like, the parasite. Mosquitoes are vectors. Mosquitoes are intermediate host, and here the commonest ones are the carriers in Africa as Anopheles. Here it is Culex, India is Culex, and some places they have Mansonia also. So Wuchereria bancrofti is the main causative agent of lymphatic filariasis. 15 million cases worldwide, out of which roughly divided among India and Saharan Africa. So we are accounting for 50% of the cases of filariasis worldwide. Okay. So as I said, Central Africa, India, Thailand, Malaysia, Philippines, Pacific Islands, Haiti, coastal Brazil. So again the same thing, we are getting a different picture here. Lymphatic filariasis endemic countries. Now this worm is about 8 to 10 millimeters in length. So like adult world will be like this, approximately this much. Okay. And 0.24 to 0.3 millimeter in diameter. Male is 40 ml, the female is bigger than the male. Okay. So this is a rough length of the parasite. So the parasite, once it enters the lymphatic tissue and blocks it, that's how the problem starts. So you have this is the adult parasite, this is the Microfilaria. Microfilaria is small, 240 to 300 micrometers, and this has sheath, it has got a cover and has nocturnal periodicity, which means it comes only in night. Now, this is something very peculiar about Culex. To identify, about Filariaria, to identify the thing you need a specimen which is taken showing the Culex or the what do you call the Wuchereria or the Microfilaria. That can be only taken at night, because night is the time where they move the maximum. So that is what they mean by nocturnal periodicity. Okay. So how does the larva appear? So this larva appears like this. Okay. Now this is the adult, 8 to 10 millimeters. Larva is much smaller. It can be seen individually under a microscope. The only thing is that it can only be seen if the load is high, and that occurs only during night time. So if you do a blood sample in the daytime, you will not get it. If the blood sample is done at 10 o'clock in the night, you will get it. That is one of the problems with the larva. So infective larvae transmitted by infected mosquitoes during a blood meal, and the larvae migrate to lymphatic nodes and vessels, where they develop into Microfilaria producing adults. So larvae are transmitted by the mosquitoes. The larvae migrate to lymphatic vessels and lymph nodes, where they are developed into Microfilaria producing adults. The adults live in lymphatic vessels. So just imagine a 10 mm worm is in your lymphatic system, and they can live for several years. The female worms produce Microfilaria which circulate in the blood. Okay. So here after the Microfilaria develops, it becomes an infective filaria form, and which actually affects the mosquito again. So next time the mosquito bites, that filariform mosquito enters the mosquito's body and then again migrates to the lymphatic vessels and lymph nodes of the human host, where they are develop into adults. Okay. So this is the same thing. This is a picture of this. First, let's look at this. Here the mosquito is taking the blood meal. Okay. Type 3 larvae enters the skin. Then the larvae it develops here. The adults come to the lymphatics. Adults produce sheaths. Okay. And that again shed microfilaria that reaches the bloodstream. Mosquito again takes the larvae again. Then type 1 larvae, type 2 larvae, type 3 larvae migrates to the head of the mosquito, and then again it hits the human again. So it's a cycle. Okay. So first thing is mosquito takes the blood meal. Then the human stages are here. Adults in lymphatics, adults produce the sheath microfilaria. Mosquito again takes the microfilaria, and then it becomes type 1 larvae, type 3 larvae, and then migrates to the head and Mosquitoes proboscis. Okay, so once again the same thing. So where can we stop it? The second one is the human stage, adults in lymphatics. Adults produce sheath microfilaria. Then mosquito takes a blood meal again. And then again the mosquito again it develops, the whole cycle starts all over again. So what we can do is we can only, there is one diagnostic scale, diagnostic stage and one infective stage. This is the diagnostic stage, sorry, this is the infective stage. Diagnostic stage is here, where you can see the microfilaria, and that's all, okay. So why clinical manifestations? Obviously the worms, they, when they block the lymphatics, that's the time when the manifestations occur, the presence of living and dead worms, and also thrombus, inflammation and immune reactions. So this basically affects the lymph nodes. And as a result of that, what happens? You have genital damage causing hydrocele and also lymphedema or elephantiasis. Now what is elephantiasis? Anybody knows what is elephantiasis? What is elephantiasis? Bola? Huh? 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 What? Huh? No, so that you're saying swelling of the feet. What is elephantiasis? Okay, elephantiasis is swelling of the feet caused by Vaccination bankrupt. No, but what is the word? Why elephant? Why the word elephantiasis? Because it's like an elephant's foot basically, okay. So what is elephantiasis? Thickening and hardening of skin, increased body size due to masses of worms all over the body, and also there is in the nose, and there is also eosinophilia, heart failure and breathing difficulty. Now here is some pictures of the thing. You have symptoms like fever, kidney damage, skin abnormalities, elephantiasis, swelling of limbs and genitalia. Males, there are enlargement of scrotum, penis retracted under skin, spermatic cords increased. Females, there is long tumorous mass covered by thickened ulcerated skin develops in the vulva. So these are the things which are there in the filariasis. So here you can see this. If you compare these two legs, this leg is, what is wrong with this leg? How does this leg look like? This leg is obviously swollen. It's got signs of elephantiasis. So then you have chronic, acute and asymptomatic presentations. Chronic ones, the common ones is hydrocele. Then we have, as I mentioned earlier, we have lymphedema. Okay. So this is an example of a hydrocele due to filariasis. Okay. So man can develop this. No, remember one thing, not every hydrocele is due to Vaccination bankrupt. Just remember that. Just having a hydrocele doesn't mean that he's affected by Vaccination bankrupt. That could be a cause. And it stays for a long time. There's another thing called tropical eosinophilia syndrome or TES. Patient has got a cough due to allergy and cough, shortness of breath and wheezing. Okay. This is due to the presence of the parasite in the lungs. So it's also called tropical pulmonary eosinophilia syndrome. So here, once again the manifestations, commonest one is hydrocele, then elephantiasis, chyluria. What is chyluria? The passage of chyle in the urine. What is chyle? Excuse me. What is chyle? Yeah, chyle is a tissue of the lymph which comes in the urine. Then acute manifestations, acute inflammatory disease, DL, that is dermatolymphoangioiditis, viral fever, tropical pulmonary eosinophilia, acute inflammatory reaction. Then you have asymptomatic presentation. You also have other symptoms like arthritis, fibrosis, tenosynovitis, etc. So till recently it was very difficult to diagnose. Why was it difficult to diagnose? The filaria, you can't get the worms. For getting the worms, you have to do some, maybe in the MRI or something, you'll get some worms. But to prove that the filaria is there, you have to move at a time when the filaria worms, microfilaria are maximum in the blood. That is only done at night, after 10 o'clock. That's the time they move the maximum. But that is the time when most labs and all are closed, etc. But now they've started this lab test, so which which it can be done at any time. Okay. Then ultrasound can also be done where you can identify adult worms. Previously, these two things were not there. So card test is the easiest way to do it. Okay. So then you also have antigen detection by, which is the gold standard for detecting Boucheretia bancrofti. So people have with active filarial infection have elevated levels of IgA, Ig4 in the blood count, and this is done by routine assay. You can find out the increased IgM. Now, how do you manage it? The management of filaria is not easy, but you have a defective drug DEC, diethyl carbamazine, which is given 6 mg per kg for 12 days and for 6 days in Bruggian filaria, repeated 1 to 6 monthly intervals if necessary. Along with that, you can give ivermectin and albendazole. Side effects of that are headache, fever, myalgia, lymphadenopathy, and occasional rash and itching. So this is the management treating with DEC and ivermectin and albendazole. How do you prevent and management of elephantiasis? Prevention is mosquito nets. If somebody is going to stay in a Culex prone area, use mosquito nets. Insect repellents. Then voodoo healing technique, I won't come to that right now. Elevate the exercise and exercise the body part. Skin treatment, wash the area twice daily. Antibacterial cream, then decongestive physiotherapy, lymph drainage, massage, compressive bandages. Okay, these are all done for extreme cases for management of elephantiasis. Lymphatic filariasis, you give DEC and ivermectin. Now they are doing testing on doxycycline and albendazole and IEC. Okay. Tanzania, they've done testing for doxycycline, they found it effective, but the testing is in a small circle, you have to spread it more. And here it's very encouraging reports from Tanzania. Then you have albendazole and DEC given twice, altogether once a year. That is called your mass drug administration, MDA. That comes as a question in the exam. What is mass drug administration? That is a single dose of ivermectin albendazole for getting rid of filaria. It's given to everybody except pregnant women and children. Pregnant women is not given because there is a chance of teratogenicity. So how do you prevent it? By decreasing contact between humans and vectors, or by decreasing the amount of infection the vector can occur. Reduce the number of mosquito vectors, 2-drug regimen, either albendazole and ivermectin or DEC. Okay. So individuals, you use personal hygiene, personal repellents, bed nets, etc. And prophylactic regimen of DEC, 6 mg for kg per day into 2 days per month. So how can you prevent infection? Obviously, preventing mosquito bites. You don't avoid going to mosquito borne areas, and sleep under a mosquito net. Wear long sleeves and trousers. Use mosquito repellents on exposed skin. Now, just imagine a small insect or small organism, mosquito killing people. I mean, just imagine a small thing. Of course, even smaller thing, corona killed a lot of people. But just imagine for so many years, with just one bite, it causes malaria, it can cause dengue, it can cause leishmaniasis, yellow fever, JE, all these things. Okay. So these are the vectors which can cause it. So disease spread by vectors kill 500,000 people every year, and more than half the people are at risk. And these are simple ways to protect yourself. First one is get vaccinated against yellow fever and JE, install nets, window screens, use repellents, wear light colored long sleeve shirts and trousers, sleep under insecticide treated bed net, get rid of stagnant water. Okay. So this is all regarding, I think this is my last slide. Yeah. Now your friend was saying something about Papua New Guinea. Who was it who said about Papua New Guinea? I had gone for a this is not related to this exactly, but I had gone for a couple of conferences. One was to Malaysia and one was to Thailand. So Malaysia first, there was a delegate from Indonesia. They were presenting about dengue cases. So you know what is one of the treatment for dengue in Indonesia? They are saying it's a very effective method, and they are using papaya juice. Papaya juice for treatment of dengue. They showed some figures, and they said it's effective. So I was very curious. That was the time when India was having many dengue cases. The very next year, I went for another conference. This time it was this was in, this was Malaysia. Next was in Bangkok. Bangkok, there was again delegates from other countries. There was a Pakistani girl. She was in one of the delegates. She was talking about same thing. In Pakistan also, so I think, I don't remember, I think it's Multan or Lahore. They are using the same thing, they are using papaya for treating dengue and they've got effects. Of course, they have not looked at side effects, but they're saying it is. So, in some countries, they're using non-medical things for controlling dengue. That's what I just want to tell you. When he mentioned Papua New Guinea, I just vaguely remember that. Okay, so that's all for now. Thank you.